episode of Making the Rounds, we're delving into the world of epilepsy and seizure disorders. This condition affects millions of people worldwide, and we want to shed light on the importance of managing it effectively and the advancements in its treatment. To learn more about these topics or other neurological offerings at Banner Health, please visit bannerhealth.com/neurology. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. And if you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. Joining me today on Making the Rounds is Dr. Steve Chung, a neurologist specializing in epilepsy care and the medical director at the Banner University Medicine Phoenix Comprehensive Epilepsy Center and professor of neurology at the University of Arizona College of Medicine, Phoenix. Thank you for joining me, Dr. Chung, and welcome to Making the Rounds.
Thanks for having me today.
Well, we're excited to have you. So, Dr. Chung, tell us a little bit about yourself and how you got into epilepsy medicine.
Well, I'm a neurologist to begin with and decided to specialize in epilepsy knowing how much evolving field this has been the last decade. Not only we have so many different medications and surgical options, we also dive into the patient's overall etiology, cause for the epilepsy, and moving towards a cure. So that really excited me, and being part of this epilepsy journey over past 25 years now.
Well, thank you for being here, and also huge congratulations on your recent accreditation by the National Association of Epilepsy Centers as a Level 4 Epilepsy Center for 2023 and 2024. So for our listeners who are not familiar with this designation, Level 4 Epilepsy Centers are recognized for having the professional expertise and facilities to provide the highest level of medical and surgical evaluation and treatment for patients with complex epilepsy.
Yeah, thank you. It's truly a team effort to get us here. We have been level 3 for a longer period of time, but we decided it's about time to provide more comprehensive care, including the surgical entity, implantation devices, as well as other diagnostic procedures we offer. So we're very happy to be part of level 4, and we're actually dealing with a lot more patients for surgical options and surgical care.
Well, congratulations. So let's start by giving our listeners an overview of the scope of epilepsy in the United States, particularly the number of affected individuals and how many are well controlled with medications.
Yes, so we have a growing number of patients with diagnosis of epilepsy now. When I was training 20, 30 years ago, we estimated only about 1.5 million people back then. Now, our recent estimate is 3.5 million people. Interesting fact about that is a lot of people think that epilepsy are something that people are born with. But as a matter of fact, if you look at how many patients are pediatric out of that 3.7 million versus adult, it's actually almost like a 1 to 2. So there are more adult population. Some of them start to have seizures in adult life due to head trauma, stroke, brain tumor, and infection. But yet, some other patients are actually start having seizures in childhood and then growing into the adulthood. So right now, cross-sectionally, we have about 2.5 million people in adult population, age 18 and above, and remaining in pediatric population. What's more important is not all patients are going to be fully controlled with the medications or other modalities we provide. We estimate about 30% of overall population, whether they have generalized seizures or focal seizures, they tend to be refractory to various number of medications.
So, Dr. Chung, what is the current state of seizure medication management, and can you provide insights into those types of medications available for treating seizures?
Yeah, let me start with saying that epilepsy is defined as tendency to have recurrent seizures. So a lot of people use it interchangeably, but seizure is a single event. Epilepsy is more of a disease state. So seizures are actually very, very common. If you look at the newborns, we estimate 1 in 25 born these days will eventually develop to have a single seizure or recurrent seizures. When we have a single seizure, we don't necessarily treat them. It may be due to some of the provoking factors such as illicit drugs and acute head trauma, but they may not need to be treated for longer term. However, many of them, once they have at least 2 events, then they tend to have recurrent seizures, third and fourth and so on, and that's when we start treating with seizure medications. One important thing I need to mention, even though we have a 30-some seizure medications available these days, none of them is actually curing the underlying cause of the seizures. It is interesting, we kind of lump it together as epilepsy or seizures, but there are many different reasons why they have seizures. I mentioned some of the things like stroke and head trauma, more common ones, but also genetic aberrance and the birth defect. All of those things constitute having seizures. So for that reason, we don't really dive into the cause of epilepsy a whole lot. When we're treating with medications, we're just addressing to prophylactically or preventing the next seizure by providing medications.
So you mentioned over 30 seizure medications are available, and I find that fascinating that there are so many seizure medications available to our patients.
Yeah.
Can you elaborate on the challenges faced by that remaining 30% of patients who don't respond to the medication and require further intervention?
Yeah. So you don't have to fail too many medications to be established as a refractory seizure population or epilepsy. Study shows that once you fail 2 medications, not because of the side effect, but due to inefficacy, the chance for the 3rd medication to work completely is less than 5%. So that's where we draw the line. So if you fail 2 medications, we call them or eligible to be called as refractory seizure population. So only 2 out of that 30-some medications. The real challenge is then what to do with those patients. Keep trying different medications, one option, and we also have to understand finding a right medication for that patient. And that's where a little bit of art and science come together. We have to recognize some seizures medications have side effects. Actually, all of them do, but different type of side effects depends on their age, their previously seen side effects, concurrent medications, or other concomitant disease, such as a headache and mood disorder. All those kind of things come into play when you choose a medication for the individual patient. So we try to be individualize the medication, depends on their situation, seizure types and cause, and all other things I mentioned.
So Dr. Chung, let's shift our focus a little bit to the surgical interventions for epilepsy. Could you provide an overview of the various surgical modalities available for patients with refractory epilepsy?
So epilepsy surgery as an elective, we are reserving that for the refractory population that I just defined. The reason for that is even though the medication can work in some certain population, 3rd and 4th, sometimes 7th, 10th medication or combination of it, many of them still are refractory. As we mentioned, about 30%, which counts about 1 million people in America, would have refractory epilepsy that can occur monthly, weekly, or sometimes daily. That's where the surgical entity comes in. The simple idea here is if we can identify some part of the brain that's causing seizures, then we can remove that part with a various technique, whether utilizing the laser ablation or actually resection and some other ways, thermal degradation. We can actually remove that part of the brain and make them seizure-free. Overall, well-selected population, our track record shows about 85% seizure freedom if we know 2 things. Number 1, are we sure about the epileptic focus? That's number 1. And second part is it safe to take it out? Obviously, we do not want to cause more trouble by providing the epilepsy surgery. So once 2 conditions are met, then we tend to offer those who have a refractory population and have a chance to become seizure-free. So the resective surgery, whether you use a laser or knife, or sometimes with a gamma knife as well, radiation, those are really the removing the focus of the brain. Now there are different type of surgery utilizing the devices. You mentioned the deep brain stimulation. There's something called RNS and VNS, vagus nerve stimulator. Those are the devices designed to reduce the number of seizures or seizure burden rather than addressing specific part of the focus and removing that area. So the target is different. The resective surgery, our goal is to make the seizure go away completely. Devices, DBS, RNS, and VNS altogether is to reduce as much as we can, reduce the number of seizures.
So the importance of knowing the exact location and ensuring safety during epilepsy surgery is key. So you explained the differences between these surgical interventions. Can you tell us a little bit about these advantages and when they're recommended?
So if somebody's refractory to various medications, and that's probably the first thing we approach is there something we can do definitively to make your seizure go away, trying to find the focus. In order to find the focus, we have to do inpatient video EEG monitoring study where the patients are wearing the EEG and we reduce the medication, and by analyzing the video during the seizure event and the EEG electroencephalogram, we can actually come up with seizure focus. If that's not going to be enough information, we do the second phase of the monitoring. This is when we put electrodes inside the brain to make a small hole and advance the electrodes inside the brain, the targeted the area that we think the seizures are coming from, but not uncertain, not 100% certain. And with that phase 2, or we call it stereotactic EEG, then we gather more information, more specific information, and those patients may go into epilepsy surgery as well too. When we cannot find the seizure focus, or we decided that area of seizure focus is dangerous area or functional area causing more problem, if we remove that part, then we can resort to other modalities. I mentioned the DBS, RNS, and VNS. One big difference between the DBS and RNS and VNS is this. DBS, deep brain stimulation, or VNS, vagus nerve stimulator, is on and off around the clock. The stimulation is on with a specific area targeted in the brain, and the vagus nerve is on and off regardless if the person has a seizure or not. So we call it a neuromodulation. By stimulating intermittently, it somehow changes the firing patterns of the brain, hoping that will reduce the number of seizures. RNS is a little bit more specific towards epileptic zone. This is a device we put the electrodes where we think seizures are coming from, but uncertain, or the functional area. And this one is a closed loop. So device will record the seizure activities, and only when device is programmed, device is detecting the seizure itself, then deliver the electric stimulation to subdue the seizure. So this is a really on-demand closed loop versus other two, VNS and DBS, that is around the clock, regardless person has seizure or not.
And all of that is monitored by the team and the epilepsy specialist, correct?
Absolutely right. So the epileptologist will be the one who will program this device and analyzing the data, but neurosurgeons obviously are the ones who put these electrodes into the patients. We have a whole team approaching and dealing with the patients coming from outside.
Yeah.
So we try to make it very easy. The patient be referred to us, whether it's a simple evaluation or the epilepsy monitoring study or even surgical evaluation. So that's why we have a nurse navigator who can facilitate this kind of process. Not only the one way from their care to us, but sometimes relaying what we are about to do and what we have accomplished. We want to share that with the referring doctors as well too. And this again, the nurse navigator's vital function is to facilitate communication bidirectionally.
So it's clear, in what you're sharing with us, that the epilepsy surgery requires very specialized expertise. Can you shed light on why Banner Health and your center in particular stands out in this field?
Well, number of things. As you can see, this is such a team effort. I cannot do it alone. I need my colleagues' input. We have nurse navigators and MAs coordinating all these different type of evaluations and the surgical procedures, and obviously neurosurgeons who are well trained. These are not just typical neurosurgeons. They are actually trained specifically dealing with this type of epilepsy patients. So it's a team approach. And I think we are fortunate to have an excellent team. And we work together. We actually get together regularly once a week to talk about each patients that are candidate for different type of surgical entities. And we then discuss what might be the best approach to provide, whether it's a resection, laser, or further research medications, or the other devices. We then make a group decision. And this is actually vital function of our epilepsy team. And for patients, when they have some kind of a decision making, it's not just a my decision, it's like come as a group decision after talking about all the information we gather up until that point. So that's the one thing. The other thing is we like to be providing patients with a minimalistic approach. When we talk about neurosurgery, even though we have very good neurosurgeon, it is a brain surgery, and patients are sometimes reticent to go through the epilepsy surgery, and rightly so. So we like to offer the minimalist approach. If we're gonna remove the part of the brain, two things. Number one, we want to have a smallest opening or scars outside. And second, we want to remove as little as possible to retain some of the function that could be lost during the operation. So one of the techniques that we utilize often and we specialize in is the laser ablation. So rather than using typical way of a craniotomy, go into that, lifting some of the part of the brain, we used to actually take out some part of the brain that's unrelated to seizures in order to get access to the internal structure of the brain called hippocampus. And obviously that caused more problems. So now we have a technique that utilizing the laser probe, rather than removing part of it, we just poke through the brain, reaching to the deeper part of the brain causing seizures, and then the laser ablation technique. Recovery is much faster, and then it does not require craniotomy, therefore hospital stay also is quite less compared to the conventional ways of doing it.
Thank you for that. And it is, when we look at our level 4 accreditation for the Epilepsy Center, that multidisciplinary approach, our team of specialists, and our banner specialists work very close with the referring community, so the primary care, the general neurologist. Can you walk us through that referral process for epilepsy surgery, and who typically refers those patients, and what are some of those qualifying metrics that a patient needs to meet in order to consider some of these surgical interventions?
Yeah, anybody can actually refer their patients to us for epilepsy surgery or for the evaluation of epilepsy, or just a simple epilepsy treatment, since we know all different type of epilepsy medications, how the combination may not work for the individual. So the answer is anybody, but typically we have patients referred by neurologists in the region, Phoenix and sometimes Colorado, Las Vegas area, and the eastern part of California, and then the Albuquerque. So those are the more of a catchment area for us. And the neurologist cannot deal with their seizures or cannot control the seizures, whether 2 or 3 or conventional use of their medication, then they send to us. Our idea here is, first of all, we have to make a correct diagnosis. Sometimes we're dealing with something called non-epileptic seizures. So they are not epileptic seizures in classic sense, that there's no EEG markers with it. That we have to find out whether they have a true epileptic or non-epileptic, because non-epileptic patients, for non-epileptic patients, seizure medication does not work at all. It's more of approaching with the psychosocial issues. If we define the patient has a seizures, then we have to first divide into focal or generalized onset of seizures. And the reason we do that is, number one, medication choice is different. Sometimes they're taking wrong medication for their type of seizures, and we have to rectify that. Other times is patient education, that we like to provide the outcome and what we can provide for the patient, including surgical option, can be quite different when you compare focal versus generalized onset epilepsy. So right now we have patients coming from multiple states, and especially in the local area, not only the Banner hospitals, but other system as well too. We welcome anyone. I think it's a nice thing that the Banner actually accept many different insurance carriers widely. So we actually can provide more care for the patients with epilepsy.
That's wonderful. Thank you for that overview. Going back to surgical procedures and patient care, can you share with us a little bit about the after surgery care?
Yeah.
What does that post-operative care process entail? And do patients typically continue with medications?
Yeah, that's actually a very important question. So a lot of people come to us, and once they become seizure-free, not everybody becomes seizure-free, by the way, but when they become seizure-free, one of the first things they want to ask is, what do I do with the medication? Now the epileptic zone is gone, should I stop my medication? Well, we approach them more cautiously. There are many studies done. Initially, after about 2 or 3 years, we tend to stop the medication altogether. But we found out that about 40 to 30% of those population who become seizure-free after surgery, even many years later, they start having seizures again. So we don't really approach epilepsy surgery as a cure, but rather as a treatment. Therefore, many of the patients have to continue to take their medication. However, if they're taking high dosage of medication or many different number of medications, we can reduce the dose or reduce the number of medication they can take. Our optimal goal is once the surgery was successful, we want to bring down to kind of average dose of one medication rather than multiple medications.
So, Dr. Chung, at Banner University Medicine, with the University of Arizona College of Medicine, we have access to clinical trials.
Yes.
We have access to, new research and advancements in care. Is there anything on the forefront or in the future of epilepsy care here at Banner and with the College of Medicine?
Yeah, there are several things I think it's very important to mention. One is, it's not just another medication we have a clinical trials. We have sometimes very unique and very different from the existing medications, mechanistically and how it works in the body and brain. So there are the opportunities that patient otherwise would not able to test it out. So we provide those kind of access to the medication through the clinical trials. The other part is how we understand seizures and brain function overall. Traditionally, even when I was in medical school, we talked about, okay, this part of the brain controls that part of the brain controls the language, and so on. So it's very compartmentalized brain understanding function approach. But now we kind of a more fluid model. So brain is truly so, it's a network rather than compartmental function. So they're all connected, as you know. So network meaning connection, and seizure spreading. Seizure may start with a small, maybe eye twitching, and then moving into the whole body convulsion. Obviously, there's a network of neurons get involved to get bigger and convulsive seizures. So sometimes we have to address how this propagation of electrical discharges in the brain gets to the point where somebody has convulsions. So if we cannot address the very starting point or cannot find it, at least we can interrupt the neuronal network. So that's actually a new approach. Sometimes neuronal network and disturbing that is a lot more important than addressing the focus of it. And there's been studies been showing again and again how neuronal network approach of a neurological disorder, not just epilepsy, but dementia and stroke, all these kind of things, MS, all these kind of things are very important to understand how the network works. We are actually doing some studies looking at that network of the brain when patients have seizures. So we are going to be addressing the area that has a highly engaged network might be the area we need to address rather than only the seizure focus. So it has a little bit different understanding approach of a surgical end and also the understanding of the seizures. So I think that's going to be quite interesting once we have the better outcome by addressing the network rather than simply the seizure focus.
That's fascinating. Is there anything else that you want to share or any take-home messages for either our referring physician or our patients that may be listening?
Yeah, one of the things we emphasize is building the relationship with the referring doctors. We actually invite them when we have a weekly conference talking about the surgical entity, surgical patients. We like to invite those referring doctors to be engaged and involved in the decision-making process. And they'll be informed and educated as well too. So we view that as a more partnership. And I think that worked out very well for us in the region. So we're going to continue to pursue that relationship building approach for the benefit of patients and better care for the patients. One of the things I find very remarkable is how our patients are living daily with these unexpected things that can occur in any given moment. If you look at what human beings are most fearful about, it is about unknowns. You name it, and if you don't know whether it's going to happen, when it's going to happen, that's where we build our anxiety. Unfortunately, seizures are just like that. It is highly unpredictable, and it can occur any given moment without having any specific trigger factors. So I always refer our patients as very courageous people, living through these unknowns daily. And that also motivates me and our team to provide a better care for our patients.
Oh, I love that. Once a patient has been diagnosed with epilepsy, it can be life-changing. They're driving, they're caretaking, some of the things that they could do by themselves alone that, maybe they shouldn't, or it's not recommended. Is that something that you'd like to discuss a little?
The seizure patients actually face many different challenges in life. It's not just the seizures. The seizure may be once a month, maybe more, maybe less, but they have to suffer through potential side effects from the medications. And there are many unknowns in epilepsy care and associated symptoms. Common ones are the cognitive side effects. Because it's a brain disorder, a lot of people have memory function deficit, concentration problems, and job performance. Driving is another restriction. If you have seizures, you cannot drive a car until you become seizure-free for at least 90 days. That's a difficult task to achieve. So many people cannot even work properly because they can't drive a car or function properly at work due to the cognitive dysfunction. Another very important thing is emotional lability or behavioral changes. It is known that the patient with epilepsy has the highest instance of anxiety and depression than any other chronic disorders. So it is important to recognize when we approach the epilepsy patients or patients with a seizure disorder, it's not just controlling the seizures, but we have to think about some other social issues and also the other symptoms. And that becomes very important because some of the seizure medications do cause cognitive and behavioral problems. And we want to be highly selective for those medications and avoid if you already have those symptoms. Yet some medication can actually improve some of this mood and even approved by FDA for the mood disorder. So we have to know quite detail about each medication and patient history to match up and provide the best solution for the patient.
And I think that's where our comprehensive epilepsy center and the care team that we have really helps with that.
Yeah.
Do we provide any patient resources? Do we assist them once they've been diagnosed?
Yeah, so best resource that we have here is Epilepsy Foundation. It's a part of the National Epilepsy Foundation of America. And we do have a patient education symposia as well as a patient events. It could be art function or sometimes a camping for the youngsters. So there are some resources and social support for the patients with epilepsy through the Epilepsy Foundation. We, as a banner, physicians and the providers actively engage in the activities. And one of our neuropsychologists is currently on the board of Epilepsy Foundation. Yeah.
Wonderful. Well, thank you, Dr. Chung, for providing this invaluable insight into the world of epilepsy treatment and surgical intervention. And it's clear that Banner Health's expertise in making a significant difference in the lives of many of our patients that are living with epilepsy. If you want to learn more about the neurology specialists and the programs available at Banner Health, please visit bannerhealth.com/neurology for more information. Thank you for listening, and we'll see you next time on Making the Rounds.